just to give them time to come into the room. So we had a 14-year-old child, I want to call him David, at one of our clinics in Kuje. And he stopped coming for his refills. So one day, when the ART coordinator asked him why, he said, auntie, you people only give drugs, you don't even give football. So apparently, he only showed up during the holidays, and this is when his friends were around. So what we started doing then was that we birthed a new clinic idea. We called it Game and Care Sessions. What that did was the kids would come in for play, they'll come in for snacks, and they'll also come in for peer support. And yes, for their ARVs. In just 3 months, missed appointments dropped by 60%. All it took was a shift from pill counting to people centering. Across Nigeria, from the creeks of the Niger Delta to the highlands of Jos, we've seen innovations spring up, often driven by necessity and resourcefulness. Whether it's integrating HIV services into routine immunization and nutrition days, using adolescent peer navigators, or even WhatsApp reminders. These are disguised as football match banter, but one thing is clear: traditional methods won't cut it anymore. Pediatrics and adolescents need HIV services that feel less like a hospital visit and more like home. They crave privacy, acceptance, and a space to express their evolving identities, even when those identities are still trying to understand what viral suppression even means. Today, we'll explore some of those bold, contextually relevant, and often humorous innovations that are helping us reach the forgotten population in the HIV response, our children and our teenagers. Because when we get it right for them, we're not just saving lives, but we're securing the future. So let's dive in. I'll begin by introducing the panelists, who are seasoned and experienced subject matter experts. So in no particular order, I'd like to start with Professor Regina Oladokun. Please put your hands together for Prof. So Professor Regina Oladokun is a professor of pediatric infectious diseases at the Department of Pediatrics, the College of Medicine, University of Ibadan, University College Hospital, Ibadan. Can we keep clapping for her till she gets here? Thank you. She had a subspecialist clinical training in the field at Cape Town. She was a visiting scholar at the Gates Institute, Johns Hopkins School of Public Health, Baltimore, USA, and also has further experience in public health with an MPH from the University of Ibadan. She coordinates the pediatric HIV program of the University College Ibadan. At the national level, she chairs the National TB Research Task Team. She's the vice chair of the Child TB Steering Committee of the National TB and Leprosy Control Program, a member of the Pediatrics HIV Committee, as well as membership of several other committees related to infectious diseases. She is the president of the Nigerian Society for Pediatric Infectious Diseases and deputy editor of the Journal of the African Society for Pediatric Infectious Diseases. She is a member of the Education Committee and board of the World Society for Pediatric Infectious Diseases. She has published widely on her research interests in vaccine and non-vaccine preventable diseases, tuberculosis, HIV, and antimicrobial stewardship. She leads several research projects, including multi-resistant organism invasive disease in children and innovation in point-of-care technologies for HIV/AIDS. Please put your hands together again for Prof. Thank you very much. At one point, I got, tongue-tied saying pediatric infectious diseases. Did you realize that? I kept saying pediatric infectious diseases, and there's so many. Welcome, Prof. So I'd like to call Dr. Victoria Isiramen from UNICEF. Dr. Victoria. I see. Okay, so I understand that Dr. Modupe is representing Dr. Victoria. So this is Dr. Modupe, and Dr. Modupe is, she's a public health practitioner with expertise in infectious disease programming and health system strengthening. She holds an MBCHP from the Obafemi Awolowo University, Ile-Ife, master's qualifications in public health from the Hebrew University of Jerusalem in Israel, and data science from the Valencia International University of Spain. She currently serves as the PMTCT Pediatric HIV Focal Person for UNICEF Nigeria, in which capacity she acts as liaison between the joint UN team on AIDS, and relevant government agencies on all matters pertinent to PMTCT and pediatric HIV. She provides technical assistance to the national stakeholders to strengthen policies, coordination, and service delivery across the PMTC and pediatric HIV continuum of care. Please put your hands together for Dr. Modupe. Next, I'd like to call Dr. Akamu Mohammed Mujtaba. I don't know if you guys heard the Akamu part of his name. Did you guys hear that? So I'm expecting him to come here and move stuff, because if he doesn't move stuff, oh my days. Dr. Akamu, where are you? Dr. Akamu Jr., where are you? So we'll give him, there he is. Please put your hands together for him. So he's a public health professional with over 6 years of experience. He's a senior associate at the Clinton Health Access Initiative, Nigeria. He's passionate about sustainably improving public health access to quality health care through the design and implementation of health system strengthening strategies, effectively using data and eliminating financial barriers to quality health care. His experience spans viral hepatitis, COVID-19, mental health, and HIV programs. He serves on the Nasarawa State Viral Hepatitis Elimination TWG, the National Mental Health TWG, and is a member of the Pediatric Adolescent HIV Subcommittee. Key initiatives he has supported include EID integration on GeneXpert, development of the viral hepatitis M&E systems, introduction and transition to PTDG, development of family index testing reporting systems, mental health integration into HIV services, and the revision of numerous national policies. He currently leads CHAI Nigeria's mental health and pediatric HIV programs. Please put your hands together for Dr. Akamu Jr. Thank you. So finally, I'd like to call Sarah Godwin, and she works with APIN. Where's Sarah? Put your hands together for Sarah as she comes up. There she is. So she's a passionate community health and human rights advocate from Nigeria. She's committed to advancing gender equity, youth empowerment, and the HIV response. She has served in various advocacy and supportive roles with NEP1, APIN Public Health Initiatives, and iCare Nigeria. She provides legal aid, psychosocial support, and leading youth-focused HIV programs. A strong voice for adolescent girls and young women, Sarah has also partnered with Athena Initiative to promote sexual and reproductive health and rights. She leverages storytelling to amplify grassroots voices and champion inclusive, people-centered health systems. Thank you, and put your hands together for Sarah again. Sarah, do you want to move closer to the rest of the panelists, please? Thank you. And finally, I'd like to call my colleague, Mrs. Mary Treasure Ama, who is the SAPC of Cross River. Put your hands together for Mrs. Mary, please. So she's the State AIDS Program Coordinator for Cross River State. She was appointed in 2021. She previously served as the Lead Monitoring and Evaluation Officer for the State AIDS Viral Hepatitis and STI Control Program. The SAPCs in this room, you need to be putting your hands together for her as she's coming. Thank you very much. With a career spanning roles in nursing, public health, immunization, and HIV programming, she has held key positions in service delivery and program coordination. Mrs. Ama holds a BSc in health education, an MPH from Texila American University, and multiple certifications in public health, leadership and program management. She's a dedicated health professional, a trainer, a facilitator with over 2 decades of experience, and hails from, okay, you're going to have to excuse me, Odukpani local government area of Cross River State. So these are my panelists, and please put your hands together for them finally. So I think we will just quickly dive into the sessions. If you all are ready. For you, Prof. wants to take and Dr. All right, so in no particular order, I would like to start with Dr. Modupe, if that's fine. So Dr. Modupe, we're going to talk about adolescent-friendly services. So what are the most effective adolescent responsive models? For example, youth clubs, differentiated ART delivery, that you have used to address the unique needs and dropout risks in this age group. I'd like you to focus on privacy, peer support, transition from pediatric to adolescent care. Thank you.
Thank you very much, Dr. Fatima. Good afternoon again, everyone. I'd say that the question is actually tricky because adolescents live in different realities. That's the first thing. The second thing is context is very different. So what works in a place like Lagos, a metropolitan place, is unlikely to work in a state like Zamfara, for example. So we need to contextualize. So if I need to answer that question, it's to bring me back to the various platforms that we have already existing in the country. We have the adolescent youth-friendly centers, which I know that NACA is doing great work to revamp in the country. We have the Operation 000 platforms where adolescents, can get services for HIV and for other related services. We also have a platform called Ya Naija, that's Youth Alive and Healthy Adolescents. That's a government-owned platform as well, supported by UNICEF, where it's an innovative hybrid platform, that combines different model, online, offline, so that it can cater to the need of adolescents in their various capacities. So I would think, or I would say that it's important, we can't have one size fit all. It's important that we understand what works for the adolescent in our various states, and then we take it on from there. We already have beautiful platforms going. How do we ensure that these platforms are actually optimal for the adolescents to have access to? How do we ensure that we have demand creation, to be able to improve the pool of adolescents that we have? I know that for the adolescent-friendly centers, which was initially, was HIV related, but right now the scope has been expanded to other services. What are the things that we can bring in to integrate into those systems or platforms so that adolescents can come around into those platforms to get services? So looking at every of our contexts, answering the question is for us to look inwards, see what works for the adolescents, work with them, get ideas from them, and build on, from all of those strategies. I hope that answers. Thank you.
That's good enough. Thank you so much. So from what I understand, you're saying that we need to look inwards. So maybe everybody should tailor the adolescent-friendly services to what works for maybe their community or their states. And then finally, because globally we're moving towards integration, we should try and integrate other services into the adolescent-friendly services for HIV, right? All right, then. So we'll move on to, so I'll take Professor Akamu Jr., and I expect you to move a lot of stuff. Prof, are you listening? Thank you. So, we're looking at family-centered versus individualized approaches. When should programs prioritize family-centered care? So, for example, mother-child pairs, over youth-specific services, and how can both coexist without gaps? So I want you to focus on balancing caregiver involvement with adolescent autonomy. Do you have that, or do I need to say it again? Thank you.
Is this on? Okay. Thank you for applying pressure on me. Good afternoon, everyone. My name is Akotmo Muchtaba. First of all, thank you to NASCP for the opportunity to contribute to this important discussion. Now, this is quite a very interesting question. And I think my answers would really encapsulate the concepts of patient-centered care, age-appropriate disclosure, differentiated service delivery, and transition support. And so, to start with, let me start by saying I don't think it's one versus the other. It's both at different times of a client's life. Let's walk through a person's life journey. From the perinatal stage to early childhood and middle childhood, we're talking ages 0 to, let's say, 10 to 12. The characteristics of the individual at that time, it's quite clear that this person is 100% dependent on the caregiver for everything: nutritional support, emotional support, and most importantly in relation to this question, adherence to therapy. not just HIV, any therapy, malaria, antibiotics, whatnot, that child is completely dependent on the caregiver. And so I believe you would unanimously agree with me that during the perinatal, early childhood, middle childhood phases, it is important that we have family-centered services. And we have quite a number of those already. Family ART groups, family pickup groups, mother-baby cares, and what have you. Very important. But as this child or as this client starts to transition to early adolescent, late adolescent, the biological characteristics and social characteristics start to change. Right? This individual is more interested in autonomy. This individual wants to have a greater say and self-determination in their health care, in their health-seeking behavior, and probably most importantly, as they progress through puberty, they start to develop sense of self and sense of sexual identity. The needs that the health system needs to provide to this individual definitely change. We need to start considering SRH counseling, SRH service delivery, the ABCs of prevention, and whatnot. Would agree with me that the typical adolescent probably does not want to receive these services in a family-centered setting. There are more adolescent-friendly services and more individualized and adolescent-friendly services that are more appropriate at this time. We're talking peer support groups and what have you. I'm going to wrap this up by noting that I don't think it's a one-size-fits-all. It's not one versus the other. It's what's most appropriate for the client at the particular stage of the client's life. And this is why it's very important from the health system perspective. Program managers, government, implementing partners will ensure that the flexibility in the system, the capacity for healthcare workers, it's all there to ensure that patient-centered services can be delivered. I think the last point I would note on this is just a call not to leave the kids and adolescent populations behind. As we start to increase the tone of the conversation around HIV service integration, it's very important for everyone involved to ensure that these flexibility and these differentiated services that pediatric and adolescent clients absolutely need is not left behind in a one-size-fits-all approach to integration into OPD. And that will be that from me. I hope I've not embarrassed you.
This question I'm going to ask Prof. Prof, what do you think? Should he go on? Did he embarrass us? I think he did a good job. Thank you. Thank you. So I think that basically what you tried to say is that it's not a one-size-fits-all. And yes, obviously, like we said, teenagers, adolescents, they need TikTok. They need to feel like the hospital is a home. It's a place where they can come in, take their drugs, but at the same time feel comfortable. So we're going to have to start focusing on patient-centered care, differentiated service delivery, and certainly transition support. Thank you very much, Prof. Okay, so I'm going to move on to Prof now, and I'll be asking Prof and my colleague, Mrs. Mary, to talk to us, but first, Prof, about incentives and structural support. So we're going to be looking at which non-medical incentives, for instance, transportation subsidies, school support, or structural interventions such as teen-friendly clinics, which ones show the strongest evidence for improving retention amongst this population. Please focus on addressing poverty, stigma, and logistical barriers. Prof, over to you.
Okay, thank you very much, and hello, everyone. Yes, fundamentally, we need to look at poverty, stigma, and logistic challenges, because these are very important in this when it comes to the services for pediatrics and adolescents. I had to research this, mind you. So we have transport. Yes, 2 days ago, a young person reminded me, says it's T-fare. Is you elderly people, ancient people who say transport fare. He said T-fare is very important. So T-fare support and studies from Nigeria, Kenya, Uganda have supported this. So this is one. But I leave you the audience to pick out of the 5 that I'm going to list. Then we have educational support, because we did all this in the past when it was OVC, it's been renamed now. So educational support, the children and adolescents were supported with school fees, uniform, and other supplies. Then, should we be doing adolescent youth-friendly clinics that are flexible? that will be carried out over the weekend or after school, and then have youth-only spaces, have trained, friendly staff. At the end of the day, we could reduce fear and embarrassment associated with attending HIV clinic. Then number 4, peer support and mentor programs like teen clubs, OTZ, Zandiri, and what did you call yours, Dupe? Ya Niger, okay, or Ya Niger, yes. And then number 5, conditional cash transfers. So it's for you to judge the audience. Which ones do you think, or anyone who is looking after these children and adolescents, which one do you think works best, or your parents have told you, caregivers, will benefit them the most? So from my perspective, that CFA is so important.